Okay, good afternoon.
Good afternoon, Doc.
Call your classmates so we could start. Okay, so welcome to the PMCH section of our seminar. So the schedule of our week would be PMCH1 for this day, PMCH2 Tuesday, PMCH3 Wednesday, self-study day on Thursday, and we will have the exam on Friday. Okay, so we've had Dr. Peralta 1 p.m. So this would complement her um, her review lecture for PMCH1. Okay. Your biostatistics, more on your applied, but we will try to touch on it this afternoon, but will be more elaborated in your research PMCH2 part tomorrow. Okay. Okay, so of course we've we've dealt with preventive medicine for the past 3 years of your medical school, and you all know that it's a branch of medicine that concentrates on keeping people well with a goal of disease prevention and health promotion. Thus, our focus would be on the primary prevention, primary health care, and taking care of public health. So it's the science and art of preventing disease, prolonging life, and promoting physical and mental health and efficiency. So we enhance lives of patients by helping them promote their health, reduce risks, and prevent specific diseases, diagnose diseases early, improve function to reduce disability. Okay. So basic concepts, you all know the definition of health by the WHO. It's a state of a complete physical, mental, and social well-being and not necessarily the absence of disease. Okay, that is how your WHO would define health. So furthermore, it's a healthy lifestyle of living that lowers the risk of being seriously ill or dying early. Okay. So wellness. So this is an active process of becoming aware of and making choices toward a healthy and fulfilling life. So it balances mind, body, and spirit that results in an overall feeling of well-being. So it's not just your physical. There are 8 dimensions of wellness that we should strive to achieve. So physical, intellectual, emotional, spiritual, financial, occupational, and social. These are the dimensions that we have to look at. Okay. So we look at healthcare. So that is the prevention, treatment, and management of illness and the preservation of health through the services offered by healthcare organizations and professionals. So it includes all the goods and services designed to promote health, including preventive, curative, and palliative interventions, whether directed to individuals or to populations. Okay. Again, it's never enough to reiterate what primary health care is. So, primary health care is an essential health care made universally acceptable to individuals and families in the community by acceptable means to them through full participation and at a cost that the community and country can afford at every stage of development. So, this is supported by your alma ata done in 1978 and the Astana Declaration done in 2018. Okay. You will see elements of primary healthcare whenever we discuss Cuento ni Rosario, or any issue that would involve public health care. Okay. So primary healthcare would have four pillars. So it's the active community participation, intra and intersectoral linkages, use of appropriate technology, support mechanisms are made available. Okay. Of course, you have to review your elements of primary health care. So these are the 8 elements: education for health, endemic disease control, expanded program on immunization, maternal and child health and family planning, environment sanitation and promotion of your safe water supply, nutrition and promotion of adequate food supply, treatment of communicable disease and common illnesses, and supply of essential drugs. You will see that your PMCH curriculum tackled these elements in one way or another through our lectures and our discussions. Okay, so all medical schools would start with Cuento ni Rosario so that you would be aware of your social determinants of health. So these are conditions in which people are born, grow, live, work, and age. So these are shaped by the distribution of money, power, and resources at a global, national, and local levels. Okay, so these social determinants of health are mostly responsible for health inequities. So the unfair and unavoidable differences in health status are seen within and between countries. Okay, this is especially pronounced, especially in the pandemic, where distribution of resources health-wise are questionable. For example, vaccine rollout, there are certain local government units that would have more access than the others, would have more vaccines available, and not just the quantity, the kind of vaccines available. Some local government units were able to procure um, your Pfizer vaccine as to compare your Sinovac, etc., etc., etc. And thereby, you see different health inequities. And you will see this every day. You will see this in your practice, and you will see it in almost any situation that you.
Why do we store onions? Why do we put them in storage? Why are fruits and vegetables put in storage in the United States? Well, we live in North America.
Who is that? Could you mute? Okay, you are free to interrupt and unmute at any point in time. Okay, so what are the social determinants of health that we've encountered? Employment conditions. Okay, some time back, our press secretary or hierarchy said that unemployment rate of the Philippines is just 49%, etc. What are the working conditions of these workers? You have to be able to know these kinds of this type of issues. Social exclusion. Is there access to housing, clean water, your SSS, social protection systems, field health system? Is there access to healthcare, gender equity, childhood development, globalization, urbanization? So these are all aspects of your health that we should be aware of under your primary healthcare, and not just your treatment of illness or disease. And it does not stop from there, as you have learned in your biopsychosocial approach as well. Okay? Okay? So there are different indicators of health that you have encountered in your biostatistics, demography. So these are measures of health status, which can be based on mortality, the impact of a particular disease on the quality of life, and the ability to function. Okay. So you have different health metrics. So these are your years of potential life loss. So this accounts for premature mortality and death's weight depending on how many years a person might have lived. If he or she had not died prematurely, this measure gives more weight to deaths occurring in young people. Okay. So these are your other health metrics. So health status index summarizes a person's health as a single score. And we have your health profile. It seeks to rate a person's health on several separate dimensions, which can be deduced from the patient's health record and direct inquiry. Okay, so there are definitions such as your quality adjusted life years and your healthy life expectancy. What is the difference? So your quality of life is a perceived impact of illness, pain, and disability on the patient's quality of life. Healthy life expectancy is a measure that attempts to combine your mortality and morbidity into one index. So this reflects the number of years of life remaining that are expected to be free of serious disease. So for example, of course, if you are a stroke patient, serious disease would be ruled out. So you are, by that definition, you would not have a healthy life expectancy. But if you use your quality adjusted life years, even if you have had serious disease, so it would depend on perception. Okay. Same way with your disability adjusted life year. So it captures both the length of life lost from premature death and the time spent in poor health. So activity of daily living index, so measures a person's ability to independently bathe, dress, toilet, transfer, feed, and control his or her bladder and bowels. It may seem trivial to you if you think of it, but when we reach the geriatric age, simple things that we are able to do alone, we have to help in doing even simple tasks. So for example, people with frozen shoulder would have difficulty hooking or unhooking their own bra. So you don't need to reach 50 or 60 or 70 to experience that. Something as simple as that would affect your activities of daily living. So these are indices, Karnofsky and Bartel. Karnofsky is used for cancer patients. Your Bartel index is used for stroke patients. Okay. So our seminar exam would have 200 questions, 15 of which would be. Okay. So this would be levels of prevention. So suffice it to say that you remember this slide. So this is one lecture altogether in your first year. So primary, secondary, tertiary, and primordial. What are the differences? Your primordial prevention aims to establish or maintain conditions to minimize hazards to health. Okay. So your advocacies for social change to affect the whole population by public health policy is primordial. Okay. If you target the whole population but have selected groups and healthy individuals, you have your primary prevention. Okay. Secondary is early detection of disease. And tertiary prevention would be the treatment of established disease to prevent deterioration. So you're expected to know the different examples, what would be fall under your primordial, primary, secondary, and tertiary. So basically, primary is prevention, secondary is related to screening, and tertiary is related to treatment, and primordial is related to advocacies and policies. So remember that. Coming from the Okay. So as mentioned, primary prevention, secondary is screening, tertiary is treatment. Okay. So the next would be natural history of disease. So what do you have to know with this is that the natural history of disease by definition refers to the progression of a disease process in an individual over time in the absence of treatment. So if you remember, it will have three outcomes. If you get sick, what are the possible outcomes that would happen? Anyone? Sorry. What are the outcomes of disease if you remember your first year PMCH?
Doc, recovery, disability, and death po.
Okay, it's either you recovered fully, you recover but there is a residual, or it will result to death. So those are the three outcomes of disease. So these are the different stages. So first stage would be stage of susceptibility. So this is pre-disease stage. So this is before a disease process begins in an individual. The second would be stage of subclinical disease. So this is your latent asymptomatic disease stages. So there is disease process, but there are no symptoms of disease. Stage of clinical disease, of course, the symptoms have begun to produce clinical manifestations, and the stage of disability. Okay. Remember your epidemiologic triad. So of your agent, host, and environment. So more often your agent is usually biological or physical agents, chemical agents that may cause disease. In a host, so it has different demographic characteristics, biological characteristics, and socioeconomic characteristics in and working in an environment, either physical, biological, and social environment. If you add time, that would be your epidemiologic tetrad. Okay, I think this is for third year. So there are different ways where we could do health promotion. I think we will skip this. So this is, I think, third year. This is actually review for the interns as well. Okay. So remember that you have your 5-star Filipino doctor. So we aim you to be healthcare providers. That's why we aim that you be competent in diagnosing, etc. A teacher and academician. So you impart knowledge to your juniors. A researcher and a social mobilizer and administrator and manager that would affect public policy. Okay. So we have your family. So nuclear, blended, extended, single parent, and communal. So the definitions would be the nuclear would be would someone remember how these 5 family structures would be um, differentiated? Was interviewed earlier. So this would be the family aspects of your PMCH1. So nuclear, your family, just your family is involved. Extended, you have your um, other relatives living with you. Blended, two families would join and make one. Single parent, you just have one parent. And communal, you live together with the same ideals. Know the difference between a nuclear. Okay. So we have different parenting styles and children's behavior. So there is a democratic way of parenting. Most Filipino families would fall under authoritarian. Most Asian families, for that matter, permissive, rejecting, and uninvolved. Okay. So remember your family tools. Sorry. So you have your APGAR. Your scoring would be as follows. So 0 to 3 would be severely dysfunctional. 4 to 7 would be moderately dysfunctional. And 8 to 10 would be highly functional. These would be part of your family tools. Okay? Family life cycle. Okay, so we have our family life cycle. So these are your stages. An attached young adult, newly married, married with young children, married with adolescents, empty nest, and family in later years. So we would have, each stage would have different um, issues and things that you have to get over. Okay, so for example, for newly married couple, the most common issue would be failure to dissociate from your family of origin. Okay, so and the need to do first order change and your need to be second order change. You have to review as well. Okay. So you have your family illness trajectory. So stage 1 to 5. So stage 1 is the onset of illness. Stage 2 is the impact phase or reaction to diagnosis. Stage 3 would be major therapeutic efforts. Stage 4 is early adjustment to outcome. And stage 5 would be adjustment to the permanency of the outcome. Okay. So these are the other tools such as your lifeline, family map, okay, your family genogram, your screen, draw a family test, and family circle. Just review what are the strengths and what are the purposes of these family tool strategies. The life. Okay. So we have our communication skills. Okay. Review the verbal and nonverbal cues, how important it is to communicate. Okay, so it is one of the more neglected aspects of our skill set as doctors, and we just take it for granted that we have to be good communicators. Honestly, it's a gift, but it could be trained, it could be enhanced. So remember your verbal and non-verbal cues. Okay. I will provide you with the communication skills so that you could be lecture so that you could be reviewed if you don't have the lecture that I have had. Okay. I remember that the seminar exam would comprise 3 years. So more or less, it would be, what was the breakdown? I think we decided on 30, 30, 40. So 30 questions from first year, second 30 questions from second year, and 40 questions from your third year. So more or less, you estimate that more or less per topic, it would be one or two, 3 to 5 questions at the most. Okay? So manage your time well. Okay, so we have asked you to do a family wellness plan. So you, you have to create a wellness plan for the family of an index patient. So usually the questions are, what are the vaccinations that are to be given to a particular age group, and what are the screening tests that we give to a particular age group. When we asked you to do this in your first year, it was quite difficult because you have barely had your clinical subjects at that time. You have barely had your history and physical examination. But at your level, at your third year, where you have gone under your major subjects, etc., etc., it would be easier for you to do a wellness plan for the family of your index patient. Okay. So, of course, your wellness plan according to different age group, infants and children, you look at your immunizations, your health screens, newborn screen, and hearing screens. Okay, adolescents would have different issues as well. So more on your heads. So you look at your sexuality, potential for suicide, and the like. Okay. Okay. So review also your national immunization program. Know the difference between the new one and what was previously mentioned before. What are the basic changes? Your Japanese encephalitis presence, and due to the measles outbreak, your MMR is given quite earlier, and it has been being given as early as 6 months instead of the 9 to 12 months. Okay. So review the national immunization program. Often overlooked would be immunization of the adults. Okay, we do the national immunization program for our pediatric patients up to 2 years old. But what is very lacking in our society would be immunization up to the adults. Okay, barely you will see people completely vaccinated wherein they've had their boosters every 10 years or so. And more often, the vaccination catch up would occur during pregnancy, where they would have boosters of your tetanus at the very least, influenza, and your MMR at least after delivery. Okay. And no common. Okay. So this would be your types of data. So this would be the biostatistics part already. So remember your primary versus secondary data. Of course, your primary you collect for yourself, and secondary you get it from secondary sources such as your journal, censuses, etc. So you have your continuous, discrete, qualitative, and quantitative. So you have to know the difference between the types of data. So continuous would be involving decimals, discrete would be whole numbers, qualitative be um, would be descriptive or subjective, while your quantitative would be quantified or by numbers. Those types of data. Okay. Mean, median, and mode, you have to know the difference. Okay, so you have your mean, median, and mode. Okay, so this is your favorite part of the questions. So remember how to compute for mean, median, and mode. Again, testmanship. If you cannot answer, if in a time limited exam, if you cannot answer within 1 minute, one question, you skip it. It's kind of hard if you are doing an online exam because it's quite hard to go. It's difficult to go back to skipped questions. So what you could do is just make an educated guess if it will take time for you to compute. Okay? So look at your accuracy of observations. So remember these definitions. So look at validity and reliability. So what's the definition of validity? So it intends to measure what it is intended to measure. Your reliability, it's the ability to reproduce the same results over and over again. So this is important when we reach sensitivity and specificity. So accuracy and precision, this is the ability of an instrument to test to obtain the correct measure on average. And precision is the ability of an instrument test to provide the same or a very similar result with repeated measurements. So remember your arrow board. So you could be precise without being accurate if you have a systematic error, wrong calibration, wrong tearing of your weighing scale, etc. It would consistently give you the same results, but it is not accurate. So you could be accurate. You cannot be accurate without being precise, but you could be precise without being accurate. Okay, as I've mentioned, systematic error is due to wrong calibrations, etc. And random error would be errors that would occur um, spontaneously. Okay, so these would be your sensitivity and specificity. So remember your true positive rate and your specificity is your true negative rate. So remember, it's an ability of a test to detect a disease when it is present, while specificity is an ability of a test to indicate non-disease when no disease is present. And the formulas are mentioned. So TP over TP plus FN, specificity is TN over TN plus FP. Okay. So you will also have your positive predictive value and your negative predictive value. So this indicates what proportion of the subjects who had positive test results would actually have the disease. So if a person tests positive, what's the probability that he or she has the disease? That is computed by your PPV. And equation is as follows. So your NPV indicates what proportion of the subjects who had negative test results actually were free of disease. So that's your negative predictive value. That is your TN over TN plus false negative. Okay. So as far as your diagnostic trials are concerned, for you to be able to reproduce that table of your sensitivity, specificity, accuracy, PPV, and NPV, remember this 2 by 2 table. Okay. So there are two types of error. One is your alpha or your type 1 error or your false positive. So this is an error that occurs when your data leads one to conclude that something is true when in reality it is not true. So this rate suggests that the test is not specific. Okay. So you think that it's true. So when in reality it's not true. So these are the disbelievers, denial. So as to your beta rate or your false negative error, so error that occurs when data leads one to conclude that something is false when in reality it is true. So this rate suggests that the test is not sensitive. So if this is a person, what do you call this? So parang then siya because the reality is there already, but still she could not believe that the occurrence is true. Okay? So these would be the um, formula for likelihood ratio. So this is your sensitivity over 1 minus specificity. So the odds of the disease increase when a test is positive. And your negative likelihood ratio is computed as 1 minus sensitivity over specificity, and how much the odds of this disease decreases when a test is negative. Okay.
Then you
So
have
do you have So these would be the types of sampling. You have learned this. So review your simple random sampling, systematic, stratified sampling, multi-stage sampling, and quota sampling. So more often you are shown a sample design, and you have to identify what kind of sampling is shown or used.
types of sampling.
Okay.
Then we go to
So
epidemiology.
So this would be already comprising PMCH2. We'll just pass in. So pass it quickly because it would be discussed by Dr. Cruz tomorrow. So you have your case definitions. Okay. Parts of a research proposal. On Thursday, we will provide I will try to provide you with the lecturettes and some sample questions so that you would have a little practice on questions of on different topics, so that you will be prepared for your Saturday's exam. Friday's exam. Okay? Any questions for PMCH1 so far? So that is basically family medicine, your primary health care, and a little basic biostatistics. Okay. What are your concerns with regards to the seminar so that we could address it in the following days? Do you have specific questions or specific concerns so that we could adjust? Okay, this is also for those who have, well, I do understand that we have different paces of learning. So the lecture is uploaded on YouTube if you want to breeze through it at your own time. Okay. Any questions or any concerns? Like it or not,
Doc?
PMCH. Yes.
Ay, Doc, pwede pong mahingi yung PowerPoint po.
Yung PowerPoint, um, pag-usapan namin. Okay. But for now, you view it on your YouTube if you want to study. Okay? Like it or not, your PMCH, hindi siya Seminar 1, Seminar 2, no? Everything is lumped in Seminar 2. So, walang PMCH1. If you would notice, walang PMCH1 sa Seminar 1. So, you take your PMCH 3 levels at a time for Seminar 2. Okay, I will send the PowerPoint if it's okay, to your teams. Okay? Anything else?
Guys, may tanong pa kayo?
Doc, may ULMS po gagamitin sa exam sa Friday.
Actually, we haven't talked about it, but if it's Dr. San Luis, be prepared to do new LMS. If not, MS forms, if I will be doing the exam. But most likely, it's Dr. San Luis who will prepare the exam. So, sa third year ba, new LMS kayo? Mag-exam sa PrevMed?
Yes po.
Oo.
Yes,
Yun.
Doc.
That answers your question. So the breakdown I've mentioned, I think it's I think we've talked about 30 30 40. Okay. Okay. Any other questions, concerns? Okay. If there are no more questions, you may leave this call. Okay.
Thank you po, Doc.
Okay. So you are 31. How many are you sa batch?
51 po at or 52.
It's okay. So as long as you pass the seminar, that's fine with us. Okay. But the review is available tomorrow. I think it's 8 a.m. for Dr. Cruz. Okay. See you tomorrow.